going to the fourth topic, which is endodontic management of three-rooted maxillary first and second premolar by Mr. Majid Atuman, King Khalid University.
Assalamu alaikum wa rahmatullahi wa barakatuh. My name is Dr. Majid Al-Ahmari in the intern year. I came from the King Khalid University. My topic today is endodontic management of three-rooted maxillary first and second premolar. This is my college. I came from the King Khalid University, and this is my hometown. It's away from Abha around 40 to 50 kilometers. Outline of my lecture is introduction and the incidence of the three-canaled maxillary premolar in the world and the incidence of the three-canaled maxillary premolar among Saudi population. And throwing my lecture, inshallah will be, can you diagnose it clinically before the radiograph? Fourth one is clinical examination and radiographic interpretation and treatment phase and clinically cases. Can you give me more attention, because I can ask you like my student, I'm a student like all of you. When you see this patient, when you came to your clinic with this tooth, upper, second, premolar, all the root configuration and the root form is not clear. So inshallah, throwing my lecture, it will be diagnose this case and treat it. Introduction. As I want clinical knowledge of the number of the roots and the canals of the tooth, receiving endodontic therapy is a prerequisite to proper instrumentation and obturation and a successful outcome. Also, the three-rooted maxillary premolar are rare. The possibility of the extra root or canals should be borne in the mind to ensure a successful endodontic treatment. Let me go with anatomy, or the general thing. Maxillary first premolar average time of eruption is 10 to 12 years. And the root form and canal configuration generally is this access cavity is ovoid in buccal-palatally dimension, and a canal orifice lies below and slightly central to the cusp tip, as you saw in the figure. There is many types of canal configuration, and the average length is 21.5 millimeter. The bulb chamber is wide buccal-palatally with two distinct bulb, or that's mean in Arabic language قرنين مميزين أو متماثلين. The bulb chamber mesodistally is much narrowing. Divergent roots require a less occlusal axis extension, and parallel roots require more occlusal axis extension. Distal curvature in the root is not uncommon. The apically foramen is usually close to the anatomical apex. The apical portion of the roots often tapered rapidly in the normal way, in the normal endodontic, and ending in narrow and the curved root tapered. The canal orifice located centrally, and it appears a slot more than a single ovoid opening. And the maxillary second premolar average time of eruption 10 to 12. And the root form and the canal configuration is similar to the first premolar in the coronar morphology, but it is narrowing buccal-palatally and wide mesodistally. Canal orifice located centrally and appears as a slot more than a single ovoid opening. Average length is 21 millimeters. Can you tell you the incidence of the three-canaled maxillary premolar in the world? Generally has been observed as a 5 to 6% for a first premolar and 1% for second premolar. According to the Fertucci and Gagov, found 5% of 400 maxillary first premolar to have a three-canaled. That means 0.5% existed as 3 canals in single root. And 0.5 existed as 2 canals. That means 1 canal in one root and second canal in the other root. And 5% existed as 1 canal in each of the 3 separated roots. According to the Karens and the Skidmore, found 6 of 100 maxillary first premolar to have 3 canals, all of which existed as 1 canal in each of the 3 roots. According to the Fertucci, found 2 of 200 maxillary second premolar to contain 3 canals. The incidence of the 3 canaled maxillary premolar among Saudi population. That's very important. Generally, the 3-rooted 3-canaled maxillary premolar were found in 14 out of 120 maxillary first premolar specimens. That means 11.7%. And 4 out of 80 maxillary second premolar specimen. That means 5%. Morphological feature study the revealed that the map of the valve chamber floor take a triangular shape or coma shape. Important point. The incidence of the 3-rooted and 3-canaled maxillary first and second premolar is higher in Saudi population than that of the study reported in the literature. And can you see the link? It's a study done in the King Abdulaziz University in 2008. Diagnostic phase. Clinical examination and radiographic examination. Clinical examination. After you check a chief complaint and the medical history, you can examine the patient clinically. And you can observe clinically there is 3 separated routes. A careful clinical examination can be furnished the clinician with the signs that are atypically present of third root. In the buccal aspect, gingival has a flat appearance, not like a normal one, and its convexity is not in the harmony with the adjacent elements. And can you use circular probing? Normal probing can be disclose the presence of the buccal furcation. Sometimes a small depression can be present and starting from the buccal root furcation and proceeding in the acronal direction for a few millimeters, remaining mainly localized in the cervical third of the crown. A radiographic interpretation. The 3 preoperative radiographs often have to be taken at different angles. Nevertheless, a good quality radiograph taken according to the parallel technique with mesial shift technique can be provide enough evidence of the internal or external anatomy of the root to suggest the presence of the third canals. And you see that figure, it's before you saw it, and I'm drawing the red line to see the 3 canals appear to you. Another external aspect of the anatomy to be considered is that a premolar teeth with 3-rooted taper has a small taper, not like a normal one is rapidly tapered, but when you have 3-rooted, it is small tapered. When you see the mesodistal diameter of the middle third of the root, it is equal or greater than the crown of that tooth. In the diagnostic phase, the presence of the third canal is suspected. The access is through the treatment phase. So you see the radiograph and you do the clinical examination. So you can go with access cavity without perforation and without reduction more than enough. So the access cavity will be present as a mesial distal extension in the buccal portion. And the cavity will be T-shaped because that's the only morphology that represents the cnoral projection of the bulb chamber floor, allowing the straight line access to the canals. The canal orifice of multi-rooted teeth are often linked by slightly marked sulci, and this canal occurs in the three-canal maxillary premolar, with the bifurcation of the buccal canals is located in the bulb chamber. So when you do a straight line axis for the York axis cavity and the proper way, you can remove all of the bulb tissue by irrigant, especially by sodium hypochlorite. Okay. So the straight line axis reducing stress on the roots, because when you insert your file with the angle from the up of the tooth coronally to the root, you have two angles. That's more probably to fracture or transport of the canals. I'm like a student, I'm lucky. I have two patients, different patient. One of the first premolar with three canal separated root, and another patient with separated three rooted. A 35 years patient come to the KKU dental clinics with continuous pain related to the upper right region. Clinical examination is temporary filling, temporary restoration, and the X-ray interpretation. These caries reach to the bulb chamber. What's mean of temporary filling? This is this patient already visited another dentist and coming to me. So he said, I have pain. That means the three things. If the previous doctor do perforation, or an exacerbation of the bulb, or there is missed canal. This is the extra root. I can show you in the figure with the three canals, separated root. And this one, my obturation by rotary, and you can see the permanent restoration. Another case is 18 years patient, came to the KKU dental clinics with spontaneous dull pain related to the upper right back region. Clinical examination is class 1 deep cavity. That's for upper second premolar. X-ray interpretation, deep caries reach to the bulb chamber for number 115, that means is upper right second premolars. When I see this case in my clinic, I show that case. It's still young patient. The bulb chambers, as you know, in young patient, it's very wide and you can't see it. But in this patient, it's not visible. I'm not clear for me. So I think it's two canal just. When I open it, you can see it with two file. That's mean palatal with these two buccally. When I show this figure in X-ray in my computer, okay, what is that? It's not a normal way. So I go to the another clinic and open Google. What I write, upper second premolar with three canals. So I found a lot of pictures like that. It's the first time to hear about that. So I go to my clinic and I'm request for GG drills, and open the third canal in the mesobuccal direction. Yes. Case it just a 5 minutes. And this one my master cone, and this one my obturation with fiber post. I do the fiber post and permanent restoration. Discussion: the possibility anatomical configuration of the maxillary premolar as well documented in the literature. If the radiographic shows as a dully narrowing or even disappear bulb chamber, that's the canal diverge at the point into two parts. That's mean either remain separated or merge before reach to the apex. Additional, if the bulb chamber appears to deviate from the normal configuration and seems to be either triangular in shape or too large in mesodistal plane, more than one root canal should be suspected. Conclusion: proper knowledge. When you have a proper knowledge, when you have a careful clinically, when you have radiographic digitally with three-dimensional, is essentially for treatment of this endodontic teeth. Use of operating microscope or lobes can be enhanced of visualization of the bulb chamber and extra canal orifice.
Thank you, Dr. Majid.
Last thing is the popular thing in Abha, Green Mountain, and thank you.
Thank you so much, Dr. Majid. Thank you, Dr. Majid. And sorry for the interrupting, but I have to go with the time. Any question from the audience?
If you have any question, I will be happy.
Assalamu alaikum. Ziyad al-Hamad. Just one question. According to Turban Jan, when you classify your root canals, you need to think about the number of root canals and the number of foramina and the orifices as well.
Yes.
Does it always follow the number of, talking about the orifices and the foramina, does it always follow the number of root canal?
Yes.
So are they always 3 foramina and always 3 orifices? When we have 3 canals, or it can be 2 orifices?
There is a lot. In endodontic, there is a lot, but my subject today, that's me. There is 3 canals in separated root. 3 roots. It's a variation of maxillary premolars. Sometimes come 2 root or 1 root. But in some cases, this came with 3 foraminal, with 3 canals in separating roots.
In all your subjects?
Yeah.
Okay, thank you very much.
Thank you.
Any
You
other
have
questions?
Any question? I make it simply. I make it interesting presentation for all of you because I'm a dentist. I'm a student like all of you. So this lecture not for advanced prosthodontics.
Any question from the female section? Thank you, Dr. Majid. Thank you so much for this nice presentation.